said, I'm going to go into concepts of cervical cancer screening by self-sampling. I want to start out by making the statement that cervical cancer screening sample taken by the woman herself, either with or without medical staff assistant or with supervision, is a good thing. It can be done in the privacy of the woman's own home or at the clinic. And this is a key to understanding how self-sampling can improve the cervical cancer screening participation, both in organized screening programs as well as in countries without organized screening efforts. Self-samples are cervical cancer screening samples suitable for HPV tests. As of today, I'm only aware of a few studies that are actively using cervical cells for evaluation from self-samples. But HPV testing is, of course, the key to use of self-samples. As a fun fact, I can add that in 1968, when they initiated the cervical cancer screening program in the greater Copenhagen area, it was actually done by a lavage self-sample that was subsequently evaluated for cellularity. They abandoned that concept very fast. If we look at self-samples, we basically see two types: self-sample utensils, meaning different types of brushes, or urine collection devices. I'm not going to go as much into urine collection devices today as in the brush self-sampling, but I want to say that between those two options, we actually have a very broad perspective, because in some cultures, in some countries, in some religious communities, self-sampling by, for instance, the vaginal brush self-sampling is quite unacceptable. And here, urine collection devices represents a very good alternative. Nevertheless, if we look into self-sampling from the scientific perspective, it's an equally good sample as a clinician-collected sample. What we have today in terms of evidence is meta-analysis. The one I'm showing here is from Mark back in 2018. We do have comparative performance analysis of self-collected specimens and clinician-collected specimens showing that the self-collected samples are equally good. We have outcome in terms of cervical cancer prevention measured by detection of CIN2+ from clinical implementation studies. And the one shown at the British Journal of Cancer here in the middle is actually a collaboration with Suzanne Gruyère. And then we have a validation methodology already presented into the field of HPV, in this case, a paper from Mark Arbin. So we have all of the tools and we have the data to go in and design and define how self-sample can actually add to the current screening efforts. If I now turn to self-sampling in the context of organized screening, one of the key issues that we are combating is the challenge by declining participation rates. If we look at Denmark, we know that in the 23 to 65-year group, which are participating and invited for screening, we see a continuous, not a dramatic, but a continuous and steady drop in participation. The screening coverage is roughly 73 to 75%, which means that we have 1/4 of women not attending the public, free of charge screening program. On the other hand, we also know that approximately half of all newly diagnosed cancers are found in women who do not attend the screening regularly. It's a similar situation as in Denmark in all countries with organized screening. Who are the screening non-attenders? Well, it's actually a quite diverse group. Of course, we have the hard-to-reach groups that are being targeted in a high number of studies, trying to engage them to participate in not just cervical cancer screening, but all sorts of health interventions. They're typically defined by being socioeconomic challenged. They're difficult to reach. They have low income, little or no education besides primary school. But if we look at it in terms of absolute numbers, this group of women is relatively small. Then we have a slightly larger group where language and culture is prohibiting them from either understanding the value of screening or participating in screening. In Denmark, we count these being mainly European Union and non-European Union immigrants who are living and working in Denmark. And then the majority of those not participating in screening is just regular women. Those who will put up the invitation on the fridge door and then forget everything about it until they receive the first reminder, and then they'll put that one on the fridge door and forget everything about it. Or women who do not appreciate the gynecology examination connected to the cervical sampling, or women who just quite simply don't believe that screening is for them. And in absolute numbers, the regular women, at least in Denmark, constitute the majority of the screening non-attenders. What self-sampling can add in an organized screening program is that we can create a user-focused value chain with a strong focus on availability of service to recruit non-attenders into the screening. We need to make it simple. Women don't go to screening because of embarrassment, fear of the examination. They don't believe, as I said, it's relevant to them. We have quite a substantial group who thinks that they're vaccinated and therefore have full coverage, or simple procrastination. We need to make it easy. We need to make it so that the woman can choose to do a self-sample in the privacy of her own home, in her own time. We need to supply multi-language information material to overcome language barriers. And given that the internet and tele infrastructure is quite strong, online ordering of self-samples is obvious. We need basically to make ease of use when it comes to participation in screening by self-sampling. And on the lab side of all of this, we need to assure the highest quality assurance by using validated devices with stability data, validated performance of the HPV diagnostic tests applied to the samples once received in the lab. And we need to make systems to ensure that we have safe patient identification without requiring every individual woman shipped a self-sampling kit to provide us with her full ID. We need intelligent solutions. Another issue that is much discussed is how to find the right invitation strategy and what the outcome of different invitation strategies are. Here is a table we presented in HPV World for the IPVS conference in Sydney 2019, where we're looking into the outcome of opt-in studies, meaning where women are actively invited and actively have to accept before receiving a self-sampling kit. Opt-out, where women are invited and actively must decline unless we should send her a self-sampling kit. And then direct mail efforts. And one of the keys in this table that represents a number of studies, mainly across Europe, is that whether we send the invitation as an opt-in and the woman actively have to accept, or as an opt-out, where the woman actually have to say no and decline in order not to receive it, really doesn't matter in terms of participation. And that's good news because in our experience, the opt-out version, which we are currently testing, is quite expensive in terms of utensils. We're shipping out a lot of utensils and we're getting approximately 10 to 20% return. So in order to keep it cost effective, the opt-in so far, at least in my opinion, represents the best way of operationalizing self-sampling. I'm just going to share with you some self-sampling uptake and return rates from our current implementation of self-sampling. This is self-sampling offered to women as opt-in, and these women are characterized by having been unscreened for 4 years or more in the age bracket of 23 to 49, 5 years or more in the age bracket of 50 to 64. And if you follow through, what we see is we have all of the invited here. 27% accepts the invitation, and of those we ship a brush. 40% return the brush immediately, and 60% we have to remind by sending out a new letter saying, "Would you care to please return your brush?" And by the end of the day, what we have is around 17% of all invited screened by self-sampling. But it doesn't stop there, because the way we invite women means that we give them an informed option. They can choose. You can have a self-sample, or you can actually go see your own doctor. And the latter means that we have an additional 11% screened by general practitioner collected specimens after the invitation to self-sampling. So the self-sampling effort, reaching out to non-attenders in the capital region of Denmark, generates 28% screening participation amongst women unscreened for 4 years or more. So when we in studies are focusing on uptake levels on self-sampling alone, we might indeed be underestimating the effect of the initiatives. In Denmark, we are implementing a new revised national guideline by the 1st of October, which is scarily close. And here we'll have a phased implementation of primary HPV screening for the next 3 years. But as a new initiative, we'll have a national implementation of self-sampling to women who do not respond to the screening invitation by the second reminder. This is 6 months after the original invitation. Then they'll be presented with an offer saying you can be screened by your own doctor, or you can order a self-sampling kit here. I have great expectations to this particular initiative in the new screening program, and I'm looking very much forward to see how it rolls out and what the interest from the women is going to be. As I said, it's going to be nationwide, and we're going to utilize the same invitation strategy, the same utensils, and the same information material across the 5 healthcare regions in Denmark. Now, turning to something less organized, I have chosen to call it self-sampling in countries without organized screening, which also includes low and middle income countries. And this figure is from the WHO. And it's just to say that self-sampling offers itself to areas and regions where you do not have an organized cervical cancer screening program, because self-sampling can be implemented without the establishment of resource requiring laboratories at the same level required for cytology. Self-samples can be easily analyzed by HPV tests, many of those actually today being fairly automated. You just take out the brush head, dump it into a vial of diluent, put it on the instrument, and 3 hours later you'll have the HPV test outcome. So it lends itself to this, and if we look at cervical cancer screening at a global perspective, and I'm quite certain you all know these figures, the majority of the cervical cancer incidence is found in countries and areas of the world where we have less healthcare infrastructure than we do in Western and Northern Europe, US, and Canada. So self-sampling should indefinitely be considered in these areas and these countries, especially because what we know today about HPV-based self-sampling is that the analytical stability of collected self-samples allows for the adaptation to local healthcare structure. The paper shown here is a stability study we have done using a dry collected brush. And what we showed was that the analytical material for HPV testing is stable at least for 6 months at 30 degrees Celsius. We could have done higher degrees, but we rarely have such high temperatures in Denmark despite global warming. Nevertheless, the key here is that even if you have a less than well-functioning postal system, you can actually rely on having adequate samples returned to the lab for analysis. And if you combine this with the knowledge that web and telecommunication infrastructure is basically well established in the majority of areas in the world, it's easy to administer self-sampling as a healthcare service, even to remote areas. As long as you have some sort of postal service and some sort of telecommunication and web infrastructure, you can execute self-sampling as a healthcare offer. To conclude, I would say that in my view, self-sampling in the future is actually going to expand above and beyond what we have today. Because what I see is that self-sampling will become a free of choice offer in organized screening programs along with clinician-collected samples. We do know that around 2/3 to 3/4 of all women prefer to go to their own doctor to have a sample collected. But self-sampling is allowing us to offer an alternative to those women who do not prefer to go to their own doctor. So it means that we can actually do resource reallocation in the primary healthcare sector. We will basically be, I was about to say, liberate a lot of time slots with the GPs if, for instance, 1/4 or 1/3 of all Danish women, just as an example, would opt in to have a self-sample rather than a clinician-collected specimen, relieving much-needed resources for other healthcare initiatives and practices. And by the end of the day, self-sampling is going to make cervical cancer screening more accessible, cheaper, and convenient for all involved parties. If we look towards countries without organized screening programs, self-sampling enables cervical cancer screening outside the classical restraints of healthcare infrastructure. And it's just like in countries with organized screening programs, it remains a cheap and effective and very mobile, by the way of getting cervical screening out into all corners of the globe. And by the end of the day, it's also community engaging if you're utilizing web platforms and public communication in the right way. And with that, ladies and gentlemen, I thank you for your time.